се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академичните институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
More than 40,000 Teva employees who wake up every morning can be counted, as can the number of production sites in which they work around the world. What can't be counted is their motivation to enable someone, somewhere, to live better days with their loved ones. That's what counts. Teva provides 35,000 products to patients, more than any other pharmaceutical company. Every day, we deliver Teva medicines to pharmacies and hospitals in more than 60 countries. These are numbers we take pride in. But what really counts is our vast contribution to humanity. Our generic medicine saved hundreds of billions of dollars in healthcare costs over the past decade. We enable access for millions of people around the world to quality medicines. For over 100 years, Teva has pioneered scientific explorations, establishing 25 cutting-edge research centers and strategically investing in biopharmaceuticals to the benefit of current and future generations. Today, our innovation has led to more than 1,000 generic medicines being developed. These are all impressive numbers that can be counted. But what counts the most is the positive impact we make on 200 million people every day who can have access to a wider range of medicines to address their health needs. Cherish the priceless times together and live better days.
Good morning, everybody. We are starting the third day of Sophie Echo Days, which is topic is congenital heart disease. It's my pleasure to introduce my co-chairs this morning, Professor Wiley and Professor Ann Hall from Royal Brompton Hospital. The first session for this morning is very interesting, and the topic is about the transposition of great arteries. It's my pleasure to give the opportunity of Professor Yen Ho to present the morphology of this pathology in the adults, and also to share that the session will be presented from the two young fellows from Johns Hopkins Hospital, and we will inviting some of them to be online this morning for discussion. So, Professor Ho, you are.
So this session is on transposition of the great arteries, and I'm going to speak about the morphology of this entity. So to start with then, transposition of the great arteries, or TGA for short. It doesn't really mean very much if we just say TGA, because it's rather vague. So for the purpose of this talk, I'm going to focus primarily on complete transpositions of great arteries, but I will also introduce a little bit about congenitally corrected transposition. So to begin with then, complete transposition, or TGA for short, or DTGA in North America. The definition of this entity is that in terms of segmental arrangement, we can have either usual atrial arrangement or mirror image atrial arrangement happening with concordant atrioventricular connections. That is to say, the atrial chambers are connected to the correct ventricular chambers, but discordant ventricular arterial connections, meaning the wrong great arteries are coming off from the ventricular chambers. By contrast then, congenitally corrected transposition, also known as CCTGA or LTGA, is a combination of usual atrial arrangement or mirror image atrial arrangement in combination with discordant atrioventricular connections plus discordant ventricular arterial connections. In other words, both levels are incorrect. So two wrongs make a right in this entity. That is to say, physiologically speaking, there is nothing wrong with this heart, apart from the chamber connections being wrong on this side and wrong in the outflow tract. And indeed, in very old literature, we come across the occasional case report of incidental finding of this entity in autopsy series. So, in other words, a patient with this combination of lesions without any other associated malformations may indeed live to a ripe old age. So this entity then, congenitally corrected transposition, will be shown in those with usual atrial arrangement, a reversed offset arrangement of the atrioventricular valves. In a normal heart, we expect the left-sided atrioventricular valve be inserting at the septal level higher than the right-sided atrioventricular valve. But in congenitally corrected transposition with usual arrangement of the atrial chambers, so-called situs solitus, there is a reversal of this arrangement of the atrioventricular valves at the septum. And here we see the outflow tract, the right-sided ventricle giving origin to the pulmonary trunk. Morphologically, it is a left ventricle. So let's leave congenitally corrected transposition aside and focus on complete transposition instead. So as we said, the definition is that you have the wrong great vessel coming from the ventricular chamber. Clinicians talk about simple complete transposition, meaning intact ventricular septum with no major associated malformations, or complex complete transposition with various complicating lesions, etc. So to start with, look at the great artery arrangement, already abnormal situation. The right-sided atrium, with fossa over fossa here, opening to a right ventricle, tricuspid valve, septal leaflet. And this right ventricle giving origin to the aorta. You see the coronary orifice just visible there. And on the left side, left atrium into a left ventricle, very smooth upper part of the septum. And left ventricle giving origin to the pulmonary trunk and pulmonary bifurcation. In this one, there's an intact ventricular septum, as we see here in longitudinal cut. And the septum may appear rather straight, and we have a kind of parallel arrangement of the great arteries, usually, but not always. So simple transposition is listed here, but this entity may not be so simple. For example, there may be variability in coronary arteries, indeed arterial relationships, and in fundibular morphology, and so on. In contrast, the complex form would have lesions such as ventricular septal defect, which is pretty common, about 75% with malalignment of the outlet septum, bringing further complications, subpulmonary obstruction, subaortic obstruction, and coarctation, valvar anomalies, and so on. So we'll review some of these examples. So this is hard. Again, you see the more or less parallel arrangement of the great arteries open up. And we see aorta, pulmonary trunk. We begin to see a ventricular septal defect. Here's the outlet septum, rest of the ventricular septum in alignment. And here, the four-chamber kind of orientation, ignoring this sutures and baffles up here. We see the right ventricle, left ventricle, the right ventricle very much hypertrophied compared to the left ventricle. When the atrioventricular attachment of the valve, this offset arrangement, is as normal, although a little bit lessened if one looks very carefully. And this is an example of right ventricular outflow tract obstruction. Look into the right ventricle, open up, we see the ventricular septal defect here. Here's the outlet septum protruding into the right ventricle. Turn to the left side, we see the pulmonary valve up here, a little bit leaning across the ventricular septal defect. So in long axis cut, this is what we see here. Septum, pulmonary trunk, pulmonary valve, a little bit coming off from the left, right ventricle, outlet septum, and subaortic muscular infundibulum. So further upstream then, we might anticipate to find some more obstructive lesions such as a coarctation associated. By contrast then, in this case, the right ventricular view does not show the outlet septum. There's a ventricular septal defect here. Instead, the outlet septum is deviated into the left ventricle, as we see here. Here's the pulmonary valve, ventricular septal defect, mitral valve. So it's pushing into the left ventricular outflow tract, giving subpulmonary obstruction. A longitudinal cut here shows you that the outlet septum narrowing the aortic outflow tract and the pulmonary outflow tract, which is sandwiched between the outlet septum and the anterior leaflet of the mitral valve. But there may be other substrates to left ventricular outflow obstruction, as we see in this heart. Right ventricle opening up and left ventricle open up just there. Here we see the pulmonary valve, mitral valve, kind of dysplastic looking, but a bulge in the ventricular septum. So subpulmonary obstruction due to septal bulge. And as we said before, it's important to look out for coronary artery anomalies. This is the usual pattern that we find in complete transposition of the great arteries. 69% with the left coronary artery coming from this aortic sinus that's nearer to the front, and the right one coming from the more posteriorly located aortic sinus. Less commonly, this configuration with the circumflex artery coming from the right coronary artery. But when the great arteries are either at directly anterior-posterior relationship or side-by-side relationship, there tends to be more complications arrangement in the arrangement of the coronary arteries. For example, in this one here, we see the right coronary artery giving the circumflex artery over here, But here we see a coronary orifice, which is more or less obliquely through the aortic wall and very near to the commissure between two of the aortic leaflets. And this one comes up here and gives the branches to the right ventricular infundibulum, as well as an anterior descending coronary artery, and associated another anterior descending coronary artery back there. So this is an example of having had anatomical correction or arterial switch procedure with extension of the new pulmonary valve or pulmonary trunk, pulmonary bifurcation brought forward. And here the aorta has been pushed back and attached to the original pulmonary trunk. And here we see the buttons of the coronary arteries implanted to the base of the original pulmonary trunk. In this case here, there's 4 years post arterial switch procedure. We see the suture line here, and here we can just about make out the coronary buttons that have been used to reimplant the coronary arteries back to the native pulmonary valve, converting the native pulmonary valve into a new aortic valve. And these are not entirely problem-free. There have been case reports of the percentage of individuals having had post-arterial switch procedure with some sort of thickening or stenosis of the proximal course of the coronary arteries. But these are quite dated literature by now. So these might have been kind of historical reports nowadays. So the native pulmonary valve in complete transposition becomes the neo-aortic valve. And this is our post-mortem series, about 38 specimens, showing some variations in arrangement of the native pulmonary valve. So maybe disproportionate, maybe being unicuspid and stenotic. The other procedure then, in more popular decades ago, is that of the atrial switch procedure. There are 2 main types. So essentially, taking away the atrial septum, most of the atrial septum, and switching the flow across that atrial level to the lungs and to bodies. So this is an example of a post-mustard, this trouser-shaped baffle, as we see here, routing the superior and inferior cable return into through the mitral valve to the left ventricle. We see a patch used to enlarge the right-sided atrium, and looking into the right-sided atrium, we see the legs of this trouser-shaped baffle. This one leg over the orifice of the inferior cable vein. This is the other leg over the orifice of the superior cable vein, and the pulmonary veins would then run over the top of this baffle in through the tricuspid valve into the right ventricle. That is this area here. And this is an example of post Mustard's procedure, which showed then a very narrowed area where the pulmonary venous return has to come through in order to pass over the baffle. This area is the baffle, over the baffle into the right ventricle. And of course, after atrial redirection, you can end up with the right ventricle becoming a systemic ventricle. It is supporting the aorta, of course. And this is one of these cases, a very enormously enlarged heart, a systemic right ventricle. It was thickened before. I think it's gradually become thinner. And on histology, we see interstitial fibrosis and microscar in this ventricle. So that takes me through, I think, primarily complete transposition of the great arteries. And just to emphasize that simple is not so simple. You can have arterial switch and you can have atrial switch. So thank you for your attention.
Thank you, Professor Ho, for the very interesting introduction of this topic. I know that there will be questions, but maybe we will continue with the clinical part and echo methods for the analyzing these kind of patients, and then we could combine with the morphology and echocardiography findings. So it's my pleasure to introduce the next speaker. This is the Dr. Ani Doshi. She will present the echocardiography assessment of transposition grid artery before repair and after atrial switch repair and arterial switch repair.
Hello, my name is Ashish Doshi of Johns Hopkins Children's Center in Baltimore, and I'll be discussing initial echocardiographic assessment of transposition of the great arteries. I have nothing to disclose. First of all, the talk and the subsequent one on postoperative assessment and transposition of the great arteries are an introduction to echocardiographic assessment of this disease. For a thorough review, see the excellent guideline paper from the American Society of Echocardiography, available online for free at asecho.org. For this talk, we'll be discussing simple transposition of the great arteries, that is, circumstances in which the major hemodynamic defect is due to the great artery arrangement. I will not be discussing complex congenital lesions such as tricuspid atresia or double outlet right ventricle, in which the great arteries happen to have an abnormal arrangement. Now, many refer to this disease as D transposition of the great arteries, although it's not immediately clear what the D refers to, and a more specific name would be D-looped transposition of the great arteries, making it clear that this is referring to transposition of the great arteries with normal D-looped ventricles, the D coming from the Van Prague School of Nomenclature. And this is in contrast to L transposition of the great arteries, or L-looped transposition, in which the ventricles have inverted arrangement. However, the term D-looped TGA is still not 100% accurate, as a patient with situs inversus totalis with this disease would have segmental anatomy of ILL. So the same physiology, but referring to them as DTGA would not be accurate, and referring to them as LTGA would imply a different physiology. And so the best approach really is to describe the anatomy completely, either stating transposition of the great arteries SDD in the Van Prague system, or mentioning ventricular arterial discordance and atrioventricular concordance in the Andersonian system. That said, for the sake of this talk, I will be using the term DTGA for the sake of brevity. I will not be discussing LTGA. That will be covered by my colleague, Dr. Torres Vieira. But I will mention that LTGA is also not the most specific name, nor is anatomically or congenitally corrected TGA the most specific. And again, the most specific nomenclature is to simply describe the segmental anatomy using Van Prague or Andersonian system. So I'm going to discuss the relevant anatomical features in transposition, the imaging goals, the imaging protocol, and the views used to obtain those images. Now, with respect to the anatomical features in transposition, about 55 to 60% of cases have an intact ventricular septum. And in this situation, the systemic and pulmonary venous connections are normal. There's typically a left aortic arch without obstruction. And few of them have any type of aortic or pulmonary valve stenosis. The PFO and ductus arteriosus are typically present at birth. But with intact ventricular septum, the patient may need a balloon atrial septostomy to alleviate severe cyanosis. In about 40 to 45% of cases, there's a ventricular septal defect that can complicate surgical repair, both by adding another defect to the repair as well as resulting in anatomic changes that may limit the ability to perform an arterial switch operation. And so of these cases with ventricular septal defect, about 1/3 of them are a paramembranous VSD, and this is similar to any other paramembranous VSD in patients without transposition of the great arteries. They can be large, they can be small and restrictive, they can have be partially closed by accessory tricuspid valve tissue. About 30% of TGA patients with a VSD have a malalignment defect. These are typically large and unrestrictive. With anterior malalignment of the caudal septum, there's obstruction of the right ventricular outflow tract. And typically we think of this in other cases as causing pulmonary obstruction, but of course with transposition, RVO obstruction causes subaortic obstruction, aortic valve hypoplasia, or coarctation or interruption of the aortic arch. In contrast, posterior malalignment of the conal septum can cause LVOT obstruction, which again with TGA means subvalvar or valvar pulmonary stenosis. In about 25% of cases of TGA with VSD, there's a muscular defect. These are frequently multiple, typically in the mid-muscular septum, but can appear anywhere in the muscular septum. These may close spontaneously or become restrictive spontaneously. And less common are atrioventricular canal or inlet defects. These may involve a tricuspid valve straddling the ventricular septum. There may be RV hypoplasia involved, and these may limit the ability to perform an arterial switch procedure. Also rare are outlet or subpulmonary VSDs. And these, there's deficiency of the conal septum between the aortic and pulmonary valves. And so closure can be difficult. The surgeon will have to place a suture in the fibrous rim between the aortic and pulmonary valves. And this may distort the semilunar valve rims. Now, as opposed to the normal great artery arrangement in which the aortic valve is posterior and rightward of the pulmonary valve in detransposition of the great arteries, the aorta is anterior and rightward of the pulmonary valve. And this can range from a strictly anterior-posterior arrangement to a left-right arrangement, although typically it's somewhere in between. Defining the coronary artery arrangement in TGA is essential in preoperative imaging to understand the feasibility of coronary artery transfer during the arterial switch operation. And there are two systems to describe the coronary artery arrangement. The first is using the typical echocardiographic or diagnostic imaging convention that is viewing the valves from the inferior surface. Now, if the semilunar valve arrangement is oblique, we typically define a left anterior and right posterior facing sinus and describe the corresponding coronary arteries. For example, we would say the left main, left anterior descending, and left circumflex coronary arteries arise from the left anterior facing sinus, and the right coronary arises from the right posterior facing sinus. If the semilunar valves are anterior posterior, we'll define a left facing and right facing sinus. And if they're side by side, we'll define an anterior facing and posterior facing sinus. Now, there's also the Lyden Convention, which is more useful for the surgeons who are viewing the valves from above and looking at the great vessels in relation to each other and not in relation to the anterior, posterior, left, right anatomic planes. And the way to think of this is to imagine standing in the aortic sinus that's farthest from the pulmonary valve here, and standing from the superior end. And sinus 1 is on your right-hand side, and sinus 2 is on the left-hand side. Now note this may be the opposite of the anatomic right and left. And so here, for example, sinus 2 is the right-handed sinus, which is actually on the patient's left side because we are facing posteriorly toward the pulmonary valve. Now, after defining sinus 1 and 2, the coronaries that arise from that sinus are listed. For example, in this so-called usual coronary artery arrangement, the left anterior descending and left circumflex coronary arteries arise from sinus 2. So we have, sinus 1, which is the right-facing sinus. And so we have 1L circumflex, and then sinus 2, which is the left-facing sinus, or the left-handed sinus, rather. We have the right. Now, regardless of which system is used, it's important to have a common language within a congenital heart center, especially with respect to communication between the cardiologist and the cardiac surgeon. These are the typical patterns of coronary arrangement in DTGA, the so-called usual coronary arrangement in which the left system arises from the left or anterior facing sinus and the right coronary artery arises from the right or posterior facing sinus. This is the most common, with 65% of patients having this arrangement. Second most common is the left circumflex arising from the right coronary artery, and followed by the third most common, which is a single coronary artery from the posterior facing sinus or sinus 2. Together, these three make up over 85% of the coronary artery arrangements, with some more unusual arrangements listed here. With respect to the initial study, there are several things we need to delineate. First, we need to confirm the segmental anatomy, the systemic and pulmonary venous connections, as well as the ventricular looping, confirm that this is D-loop transposition. The atrial septum, including any atrial septal defects, atrioventricular valve morphology and function, the ventricular size and function. This is partially to confirm that a two-ventricle repair can be performed. Ventricular septum to identify those ventricular septal defects. Again, obviously the ventricular arterial connections to determine any presence of outflow tract obstruction, stenosis or valvular regurgitation, the semilunar valve arrangement and coronary arrangement, as we discussed previously. And then finally, we want to visualize the ductus arteriosus and identify any aortic arch abnormalities. The views we use for these include the subcostal view, which will show us the segmental anatomy, the atrial septum, the ventricular septum, the outflow tracts, and the great artery arrangement. In the peristernal view, we can also visualize the great artery arrangement. We can see the vessels in long axis, and in short axis, we can see the semilunar valves, as well as the coronaries, and whether the commissures of the semilunar valves are aligned. We can also identify the ventricular, we can also sweep through the ventricular septum to identify any ventricular septal defects. In the apical four chamber view, we can visualize the ventricular size and function, look for atrioventricular valve stenosis or regurgitation, and also for outflow tract obstruction. And then finally, from the suprasternal notch, we can visualize the ductus arteriosus and the aortic arch. So these are subcostal views of a patient viewing the atrial septum. Here's the left atrium, right atrium. We see a secundum atrial septal defect with left to right flow. The subcostal view is also useful for echocardiographic guidance of balloon atrial septostomy. Here we have a septostomy balloon crossing from the right atrium to the left atrium and being inflated. And in the second view on the right, we see the septostomy balloon being pulled across. This is the same patient. This is a second pull, a little bit more gentle this time. And then finally, we can visualize the final result of the atrial septostomy. Here we have an aneurysmal atrial septum and two atrial septal defects. From the peristernal long axis, we can see the great vessels in long axis. Here's the aorta anterior and the pulmonary artery posterior. This is a useful valve for defining the aortic and pulmonary valve annulus sizes to confirm that an arterial switch can be performed. We can also see any VSDs in this view. Here's a VSD here. We can also look to see if there are malalignment VSDs. And so here we have an anterior malalignment VSD. This is the pulmonary valve that is displaced anteriorly. The aortic valve is not seen here, but again, with anterior malalignment, we have RVOT obstruction, which is the aortic outflow. And in this second view here, we have posterior malalignment of the ventriculars of the conal septum. And so we see that this is the aortic valve anterior here, and this is the pulmonary valve, which is slightly hypoplastic because of the posterior displacement of the conal septum. The peristernal short axis is useful for semilunar valve arrangement. This is kind of, again, the kind of oblique arrangement of the aorta anterior and rightward, and the pulmonary valve posterior and leftward. This is more of the anterior posterior arrangement where the aortic valve is directly anterior, and then a more of a left-right arrangement where the aortic valve is directly rightward of the pulmonary valve. Here in this one, in the side-by-side view, we can actually see that the commissures for this patient are not well aligned, and this will complicate the coronary artery translocation during the arterial switch operation. The coronary artery here from the anterior facing sinus will have to be transplanted slightly farther to actually implant in the sinus here to go past the commissure. In the peristernal short axis, we can also define the coronary arteries. This is a patient with usual coronary artery arrangement. So here is the left anterior descending and left circumflex coronary arteries arising from the left anterior facing sinus. And then here from the right posterior facing sinus, we have the right coronary artery. Here is a patient with a circumflex arising from the right coronary artery here. And again, this is the second most common type. And from the apical views, we can assess ventricular size and function. We can look for mitral or tricuspid stenosis or regurgitation. We can also look for outflow tract obstruction. Here is a patient with anterior malalignment of the coronal septum and anterior malalignment VSD. And we can see that there's outflow tract obstruction of the aorta here. And here's a patient with posterior malalignment VSD, and you can see that the pulmonary valve has some subvalvar and valvar pulmonary stenosis. Finally, from the suprasternal notch view, we can assess the pulmonary patent ductus arteriosus and aortic arch. So here's a patient with a normal aortic arch, and we can see that the ductus arteriosus is flowing all from the aorta to the pulmonary artery, both in systole and diastole. And in contrast, here's a patient who has a anterior malalignment VSD, and as a result of that, has a aortic coarctation, which we can see on 2D echocardiography here. But also we see that during ventricular systole, there's pulmonary artery to aortic flow in the ductus arteriosus, indicating that there's obstruction proximal to that insertion point. So in summary, DTGA seems like a simple disease, but does require a thorough preoperative imaging study with particular attention to the atrial septum, the ventricular septum, presence of any outflow tract obstruction, semilunar valve arrangement, coronary arrangement, and the ductus arteriosus. If there's concern for RVOT obstruction, one must also be sure to assess the arch as well. Thank you very much for your attention. Hello, this is Ashish Doshi, and I'm going to be speaking to you again today about echocardiographic assessment of repaired transposition of the great arteries. Again, I have no disclosures. The mustard procedure and the sending procedure, collectively known as the atrial switch operation, was the standard approach to repair DTGA until the mid-1980s. Using an intra-arterial baffle, the systemic venous return from SVC and IVC is routed to the mitral valve, and the pulmonary venous return is routed to the tricuspid valve. The right ventricle then serves as the systemic ventricle, pumping into the aortic valve and the body, whereas the left ventricle serves as a subpulmonary ventricle. The mustard or sending procedure could be performed later in infancy and does not involve manipulation of the coronary arteries. In contrast, the arterial switch procedure provides a more anatomic and physiologic correction of TGA, but does involve the technically difficult transfer of coronary artery origins. Additionally, the procedure must be performed in the first few weeks of life before the left ventricle loses muscle mass from pumping against the low resistance pulmonary vascular bed. Because of the additional technical difficulty, the arterial switch initially had a higher early mortality rate compared to the atrial switch, although with improvements in surgical and perioperative care, early mortality for the arterial switch operation is now well below 2% in the developed world. Additionally, the atrial switch has a higher late mortality due to systemic right ventricular failure. This plot shows the gradual adoption of the arterial switch operation at a high volume center in Munich, and is similar to the adoption of the arterial switch in the rest of the developed world. And most patients today living after an atrial switch in the developed world are over the age of 30. However, the atrial switch is still being performed in resource-limited countries. This is a study from 26 sites in 15 countries from the International Quality Improvement Collaborative for Congenital Heart Surgery in developing world countries. In this cohort, atrial switch was performed in 1 out of every 7 to 8 patients with transposition of the great arteries during the period of 2010 to 2013. In-hospital mortality was lower for the atrial switch compared to the arterial switch, particularly when there was a VSD involved. The third column here, 2S ASO, indicates a 2-stage arterial switch in which the patient initially undergoes placement of a main pulmonary artery band to provide a high afterload to the LV such that it would not atrophy over time. And this allows for the arterial switch to be performed at a few months of age, at which time the procedure may be more feasible due to the increase in the patient's size. Now, of note, there are other surgical procedures for TGA when there is outflow tract obstruction, such as the Rastelli procedure, the REV procedure, the Nakaido procedure. I will not be discussing those in this talk. When evaluating a patient with an atrial switch, that is a muster or sending procedure, the main sequelae to evaluate on echo are the presence of systemic or pulmonary baffle obstruction, the superior limb of the systemic venous baffle, that is from the SVC, is the most common site of obstruction, particularly in patients with a transvenous pacing lead in the SVC. Baffle obstruction is more common with the muster procedure compared to the sending procedure, since the muster procedure uses prosthetic material for the baffle. The superior limb of the SVC baffle, the superior limb of the systemic venous baffle is well visualized from the apical view, as is the pulmonary venous baffle. The inferior limb, that is the IVC limb of the systemic venous baffle, is not very easily visualized by echo, but it is rarely obstructed due to the relatively large size of the IVC. Baffle leaks can occur between the pulmonary and systemic venous baffles, primarily at the anastomosis of the baffle with the atrial wall. Physiologically, these leaks act as a left-to-right shunt with flow from the pulmonary venous baffle to the systemic venous baffle. These can be identified using color Doppler, but if the imaging windows are not adequate to visualize the baffle, one can use injection of agitated saline or even TE. Tricuspid regurgitation can result from annular dilation and is problematic, as the tricuspid valve is the systemic atrioventricular valve. This can worsen right ventricular dysfunction. And of course, as the right ventricular anatomy is not designed to pump against systemic vascular resistance for several decades, the systemic RV is at high risk for dysfunction and failure. Unfortunately, due to the complex shape of the RV, we lack validated quantitative metrics for RV function. There are various methods such as tricuspid annular plane systolic excursion, TAPSE, fractional area change, global longitudinal strain, but none of these have been really validated in this population. And all of them need to be interpreted in the context of the degree of tricuspid regurgitation. Often, qualitative assessment is still the preferred method of assessment. Finally, pulmonary hypertension can result due to pulmonary venous baffle obstruction or due to right ventricular failure. And to evaluate the pulmonary arterial pressure, we measure the peak velocity of the mitral regurgitant jet, since the LV is a subpulmonary ventricle. So this is the apical four-chamber view showing the systemic right ventricle and the subpulmonary left ventricle. We also see the pulmonary venous baffle here, which is better seen with color Doppler. You see the pulmonary venous flow coming across and into the tricuspid valve. Over here on the right side, we see the systemic venous baffle, the superior limb of the systemic venous baffle coming over to the atrial, to the mitral valve. Again, the inferior limb of the systemic venous baffle is often not well visualized, but is rarely obstructed. Here's another patient with a better image showing the pulmonary venous baffle here and the superior limb of the systemic venous baffle. Here's the actual baffle itself, separating the systemic and pulmonary venous return. And as we tip anteriorly, we see this flow from the pulmonary venous baffle into the superior limb of the systemic venous baffle, representing a baffle obstruction. A baffle leak. Here's the right systemic right ventricle with the tricuspid valve, and with color Doppler, we see tricuspid regurgitation. Here's a patient with severely decreased right ventricular function. We can see that there's a transvenous pacing lead crossing the mitral valve into the left ventricle, and there's a significant amount of mitral regurgitation. If we obtain a Doppler tracing of the mitral regurgitation, we can obtain an estimate of the left ventricular systolic pressure, which is again the subpulmonary pressure. So this gives us an indication of the pulmonary artery pressure. Now moving to our arterial switch, the following sequelae can be evaluated with echo. Coronary artery stenosis due to occlusion or kinking after coronary translocation, and it is an important cause of early mortality after the arterial switch. It should be evaluated in the immediate postoperative period, as well as in any patient with new wall motion abnormality or any signs of ischemia. The long-term fate of these reimplanted coronary arteries is not really well known, as the earliest arterial switch patients are only now in their 5th decade of life. And so in all arterial switch patients, it's important to assess ventricular function, including evaluating for regional wall motion abnormalities. Supravalvar neopulmonary stenosis can occur typically at the site of the anastomosis. Additional branch pulmonary artery stenosis can occur due to the Lecomte maneuver, in which the branch pulmonary arteries are pulled anterior to the ascending aorta and draped on either side of the ascending aorta. And this stretches them somewhat, particularly the left pulmonary artery. Supravalvar neo-aortic stenosis can also occur at the suture line. This is best assessed from using the right upper sternal border view. Progressive neo-aortic root dilation is common, although it rarely leads to morbidity or any kind of need for a reoperation. The diameter of the neo-aortic root should be measured in the peristernal long axis in the standard fashion. And then finally, neo-aortic root regurgitation is, neo-aortic valve regurgitation is common, but severe regurgitation occurs only in 1 to 2% of patients. These are Trans-Esophageal echocardiogram images from an arterial switch operation performed recently at our institution. On the left image, we see the reimplanted short left main coronary artery, which bifurcates into circumflex and left anterior and descending. And then on the right image, we see the right coronary artery, and both of them have normal antegrade flow and diastole. Supravalvar neopulmonary stenosis can be evaluated in the apical or subcostal views with the probe tilted anteriorly or rightward. And so these top 2 images show the subcostal short axis or parasagittal view with the aortic valve on the patient's left and the pulmonary valve on the patient's right. And we see this narrowing on 2D and corresponding aliasing on color Doppler. In the peristernal long axis view, linear echo density is seen here, likely representing the suture line, and we see corresponding aliasing of that level. We also see some trivial neopulmonary regurgitation here. Branch pulmonary stenosis is best evaluated in the high peristernal short axis, and in many patients this can be difficult to visualize as they're so close to the transducer. But these images are from an infant who underwent arterial switch with the Lecomte maneuver 2 months prior. And so in this image, the branch PAs are seen draping over the ascending aorta here. With color Doppler, we see aliasing in the right pulmonary artery as well as in the left pulmonary artery. And so, as mentioned, the left pulmonary artery is the one more commonly has branch pulmonary artery stenosis due to the main pulmonary artery being pulled anteriorly and rightward during the arterial switch, and that results in increased tension on the left pulmonary artery. Supravalvar neo-aortic stenosis can be difficult to visualize from the apical or the peristernal views, but an accurate Doppler measurement of the ascending aortic valve reading can be obtained from the suprasternal view here. And finally, progressive neo-aortic root dilation is common after the arterial switch, but it rarely results in morbidity or need for reoperation. The risk factors for root dilation include the presence of a VSD and the previous pulmonary artery band, potentially as part of a 2-stage arterial switch procedure. Neo-aortic valve regurgitation can be seen, although as mentioned previously, it is rarely severe. And so this patient has trivial to mild neo-aortic valve regurgitation and some mild neo-aortic root dilation. So in summary, echo assessment following the atrial switch should focus on the assessment of the atrial baffles, as well as assessment of the right ventricular function and tricuspid regurgitation. Following the arterial switch, the assessment should focus on the supravalvar aortic and pulmonary areas, the branch pulmonary arteries, as well as the neo-aortic root. And coronary artery origins and ventricular function should always be considered in these patients, particularly when they present with signs of ischemia or regional wall abnormalities. Thank you very much for your attention.
Thank you for the nice presentation, Dr. Doshi. I think we could, starting with the small discussion, I would like to invite Professor Ho. There is no still question, but I think we could analyze how is going actually with the right ventricle after the switch, arterial switch and atrial switch, because the right ventricle is more damaged in that population.
With atrial switch, we already know that the right ventricle becomes a systemic ventricle, and it does have long-term consequences. As we see in histology, there's increased fibrosis and so on, which is not really helpful to the ventricle myocardium. In terms of atrial switch, I think you would get away because your ventricles are now back to what they're supposed to be doing. So unless you got further upstream obstructive lesions, I think you would be fine. Although I have no information whatsoever on that front.
Yes, the systemic right ventricle more or less is damaged from the fibrosis, and but that fibrosis, I think, more or less it's connected with the left ventricle also, and we could find some of the measurements with the patients that we analyzed in our hospital a couple of years ago, especially for the great transposition, that the left ventricle is also damaged especially from some of the segments, and the septal and the anteroseptal wall from that fibrosis in the right ventricle, which is involved.
It could, of course, be more widespread because what the function, the ventricles have to work together, isn't it? I mean, if you damage one ventricle, you're going to have consequences on the other ventricle.
Yes, I don't see the Professor Lee is here, but
I think she has to do some echoes.
Yeah.
Apparently.
Okay.
Yeah.
And because there is one small question from yesterday, which we see now today, and but it's very nice to have the answer. How could we differentiate the inlet perimembranosus VSD from IVSD with only ventricular communication, since both have no offset? I think it's very difficult to analyzing this type of communication when we have the actually only the echo.
I think so. I think it would be difficult because we would say that if you have a perimembranous inlet VSD, you have the two valves on the top of that VSD. Yeah. So to distinguish that situation from an atrioventricular septal defect that has only interventricular communication, we would anticipate the leaflets to be attached to the underside of the atrial septum. So true, the image you will see will be exactly the same on four-chamber orientation. But if you were to go on short axis and you look up and look at the valve arrangement, you would not find a mitral valve in an atrioventricular septal defect. So I think that would be the distinguishing factor.
Maybe the other imaging techniques like the cardiac MRI and CT will be more helpful in that case, actually.
Yes.
Yeah. Okay, thank you. Thank you. So I would like to continue with the next presentation. This is the echocardiographic assessment in congenital corrected transposition of right arteries. It's my pleasure to introduce Professor Guillermo Vieira from Johns Hopkins Hospital.
Greetings, everyone. My name is Guillermo Torres. I am a pediatric cardiology fellow here at Johns Hopkins, and today I will be discussing the echocardiographic assessment in congenitally corrected transposition of the great arteries.
The outline for this talk is to initially describe the nomenclature, morphology, as well as the pathophysiology associated with congenitally corrected transposition. Also describe the most common associated lesions with this defect, describe the pre and post-operative echocardiographic assessment goals, and then also some special considerations when we're imaging the adult. Regarding the background of this lesion, so it's referred to a set of connections whereby the vena cava actually connect to a morphologic right atrium, but this right atrium actually enters into a morphologic left ventricle, which is right-sided, via the mitral valve. This LV then ejects into the pulmonary artery, and then pulmonary venous return is actually normal and empties into the left atrium. This atrium empties into the morphologic right ventricle, which is left-sided via the tricuspid valve, and then the RV ejects into the aorta. Regarding nomenclature for congenitally corrected transposition, that has multiple names and it's very confusing. It may also be known as isolated ventricular inversion, double discordance referring to both the atrioventricular as well as the ventricular arterial discordance. It may be physiologically corrected transposition, emphasis on physiologic correction since not anatomic. The RV is the subaortic ventricle supporting systemic circulation, and then the LV is the subpulmonary ventricle, giving rise to the pulmonary trunk. It may also be referred to as L transposition. This is a non-specific term, as the L might be related to ventricular looping or to the actual spatial position of the great vessels. L loop, TGA, would be more specific, where the L loop refers to the ventricular looping. Here we have some features that suggest CCTGA on the apical fourth chamber seen on the left. They have a presence of a left-sided atrial appendage, which then drains into an enlarged and coarsely tuberculated chamber with septal attachments, which are suggestive of a morphologic right ventricle. On the right, you have an image to compare and for kind of guidance. It's an apical fourth chamber as well, but the transducer has an interior sweep to image the parallel position of the great arteries. Note the leftward position of the aorta in relation to the pulmonary artery with its perfect bifurcation. So morphogenetically, the primitive cardiac tube is anchored at one end by the sinus venosus and at the other end by the truncus arteriosus. It loops to the to the right normally, giving rise to the normal segmental anatomy that we know. In congenitally corrected transposition, this unfortunately doesn't happen, and looping is actually to the left. This abnormal cardiac looping then brings the morphologic left ventricle to the right and the morphologic right ventricle to the left, and usually results in transposed great arterial positions. Associated lesions with congenitally corrected transposition, first and foremost, are ventricular septal defects, which are seen in around 60 to 80% of cases. Here, seen and visualized, it's actually a dextro transposition of the great arteries, but the configuration in regards to ventricular septal defects is actually quite similar. They may be doubly committed, perimembranous, inlet type ventricular septal defects, or muscular. But by far, the most often is the perimembranous ventricular septal defect, and it's unrestricted in nature. This, in terms of mechanism, the L looping leads to malalignment of the atrial and ventricular septae. The degree of deviation, therefore, may determine the gap between the septae, and it can actually affect the size and the extent of the ventricular septal defect. Another common associated lesion is the left ventricular, or in this case, pulmonary obstruction, which is seen in around 30 to 50% of cases. The mechanisms leading to this obstruction may be either muscular, with edging of the subpulmonary outflow between the infundibular septum and the free wall, or maybe fibrous, with contribution from the membranous septum or the actual mitral valve or tricuspid valve tissue. Seen here is a subcostal long axis view, focus on the left ventricular outflow tract obstruction with evidence of flow acceleration below the level of the valve. Shown here is a Trans-Esophageal echocardiogram in 4-chamber view. demonstrating atrioventricular valve tissue, which actually extends into the defect. Color Doppler is not demonstrated on this view, but you can actually, it would actually show flow acceleration also at the level of the left ventricular outflow tract. Another example here, we have a 9-month-old, so a little bit uncommon. It's more of a pediatric lesion, right? This is an L-loop TGA with segmental anatomy SLL. He had mildly diminished right ventricular systolic function. And then seen here, again, subcostal long axis view focusing on the left ventricular outflow tract with redundant mitral valve chordal tissue in the LVOT without significant obstruction. The actual peak rating here was around 50 millimeters of mercury. Another common associated lesion is left-sided tricuspid valve anomalies. This may also be seen in up to 90% of cases. Tricuspid valve dysplasia is common with an Epstein-like displacement of the septal leaflet, tricuspid valve and/or mitral valve straddling as well. Shown to the left is a typical configuration of Epstein's anomaly. Seen here is rotational displacement of the septal and posterior leaflets, a dilated and thinned inlet portion of the right ventricular myocardium, as well as an anterior leaflet, which is usually quite enlarged or referred to as sail-like. When we're discussing Epstein-like malformation and congenitally corrected transposition, none of these features are persistent. Seen here on the right is an Epstein malformation in a 22-year-old man with severe tricuspid regurgitation. The mechanisms for the regurgitation include tricuspid annular dilation, shortened chordae tendineae, secondary to severe dilation of the right ventricle, also lack of coaptation of the leaflets, and a severely dilated left atrium and right ventricle. This was after a pulmonary artery band procedure. The evaluation of the coronary arteries is also quite essential, and particularly for surgical planning. Most prevalent is what's called a coronary artery to ventricular concordance. The coronary arteries originate from posterior facing sinuses above the aortic valve, and the distribution is actually a mirror image of normal. Shown here is the actual distribution. The epicardial distribution of the right-sided coronary artery is that of a morphologic left coronary artery, with the circumflex and anterior descending coronary arteries. And the left-sided coronary artery follows the left AV groove and supplies the right ventricle. For repairs actually requiring a ventricular to PA conduit, there are some specifications that we should consider. For example, a main coronary branch may course anterior to the pulmonary trunk in about 96% of cases, and a large infundibular branch supplying the RVOT may be found in around 61% of cases. So what are our goals when we're talking about initial as well as ongoing assessment for congenitally corrected transposition of the great arteries? Most of the assessment and the imaging goals are to establish a first diagnosis. This includes determining the actual visceral atrial situs, the cardiac orientation and position within the thorax, determining the morphology of the ventricles, the morphology of the great arteries, atrioventricular and ventricular arterial connections, origin and proximal course of the coronary arteries, as well as associated cardiac malformations as we just discussed. From a hemodynamic standpoint, it is also important to assess by ventricular size and function, evidence of pressure and or volume load on those ventricles, severity of mitral and or tricuspid valve regurgitation if present, gradient across the outflow tracts, gradient across the VSD, whether it's restrictive or non-restrictive, as well as estimation of the LV systolic pressure based on the mitral regurgitation jet velocity. We'll now go delve a little deeper in a way in terms of how each specific view will be helpful in these endeavors, starting out with the subcostal views, which may be a little difficult when evaluating the adult population. In pediatrics, it's a very valuable view since it provides us an accurate assessment of the atrial arrangement, the atrial and ventricular malalignment if present, ventricular morphology, and it's a very appropriate view for and well-aligned Doppler for estimation of the LV outflow tract obstruction gradients. We may also interrogate LV to pulmonary artery conduits with this view. Apical views, the transducer position according to standard guidelines may be important since there are specific defects in regards to segmental anatomy, which may be influenced by correct positioning of the probe, which we'll talk about a little bit later. Apical views also describe the morphology of the AV valves and also identify morphologic right and left ventricles. Hemodynamic assessment, inflows and outflows of the atrioventricular valves is also appropriate in the apical views, and we may also describe morphology of obstructions across the outflows. Parasternal views, so the parallel position of great arteries seen in the parasternal long axis view in particular usually confirms the diagnosis of transposition of the great arteries. The long axis view readily identifies obstruction across the LV outflow tract and can also shed some light in regards to the actual mechanism of obstruction. Parasternal short axis view describes the relation of the ascending aorta to the pulmonary trunk. Seen here are a couple of snapshots both of the parasternal long axis view and a short axis view. The aorta seen is anterior and the pulmonary artery is posterior, which is our first clue. To the far left is a 41-year-old man without LV outflow tract obstruction. Seen here is the arterial outflow tract parallel, and the AV valve is in fibrous continuity with the pulmonary valve as shown by the long arrow. To the right, we have a 9-month-old boy with subvalvular pulmonary stenosis as shown by the small arrow, probably from redundant atrioventricular valve tissue. Again, as stated, imaging in the adult may be quite complicated. So TEE, or Trans-Esophageal Echocardiogram, is an alternative if unable to delineate cardiac anatomy. In some cases, it is quite useful to consider injection of agitated saline, which may demonstrate appropriate systemic venous return and better delineate the morphologic right versus left ventricle. Cardiac MRI may also be a feasible alternative since it may allow better delineation of the anatomy, assessment of ventricular function, or measurement of valve regurgitation and shunts. So this is a special case of atrial situs inversus. The segmental anatomy here is IDD, or inverted atria, deventricular loop, and detransposition of the great arteries. The left-sided superior and inferior caval veins therefore empty into a left-sided right atrium, and the pulmonary veins empty into a right-sided left atrium. The subaortic RV is not inverted and lies into the right of the subpulmonary left ventricle. The aorta is right-sided and interior, located in relationship to the pulmonary artery. This patient was a 30-year-old female with congenitally corrected transposition, as previously stated, IDD, dextroversion with atrial and ventricular septal defects. She also underwent a left ventricular to pulmonary artery conduit, not well visualized here and actually better appreciated by cardiac MRI. So possible interventions are either physiologic or anatomic. So physiologic or palliative include VSD closure, the conduit as previously mentioned, replacement or repair of the tricuspid valve, pulmonary arterial banding, or pump support in thinking of possible cardiac transplantation. When considering an anatomic repair, we may do either a double switch, which includes an arterial switch and a mustard sending as shown here, or a Rastelli type repair with a mustard and sending as shown here. In some cases with a LV to PA conduit or RV to VA conduit. Intraoperative assessments, most likely preoperatively confirmation of the defect, and then post-cardiopulmonary bypass, in all cases, just assessment of ventricular size and function. For atrial switch, evaluation of systemic and pulmonary venous pathways. For the arterial switch, function of the semilunar valves and flow into the coronary arteries. When establishing a conduit and prosthetic valves, it's important to verify leaks or obstructions. Just to note, the pulmonary arterial banding during and after evaluation of the right and left ventricular systolic function will be important, as well as mitral regurgitation and gradients across the valves. Thank you very much for the time dedicated for this presentation. Special thanks to Dr. Shelby Cuddy, Professor Katarina Hristova for the opportunity to present today, and the coordinators of the event.
Thank you, Professor Dr. Vieira, for the very nice and very interesting presentation. I'm really sorry that the time differences is not available for us to make the live discussion, but we will continue with the Professor Hall to ask, because there is some questions and I think that we could make the short discussion about that. So can we explain the course of the conduction in congenital corrected transpositional great arteries? How do you think, Professor Hall?
Yes, the thing is with different terminologies, and I will try and explain. When you have CCTGA, you can have two variations of atrial arrangement. You can have usual atrial arrangement or mirror image atrial arrangement. In other words, situs solitus versus situs inversus. So let's say you have usual atrial arrangement. It means that your morphologic left ventricle is on the right side and morphologic right ventricle is on the left side. So in other words, isolated ventricular inversion. So when you have that situation, the ventricle's in the wrong positions, the conduction system for the atrioventricular conduction system rather is in a totally different position compared to a normal heart. Instead of running a posterior course, it runs anteriorly. So let's say you have a ventricular septal defect in that heart with corrected transposition, congenitally corrected transposition. You would then have an anteriorly situated atrioventricular node, nowhere related to the triangle cock. So forget about triangle cock. It will be anteriorly located, quite close to the os of the right atrial appendage. And then the atrioventricular bundle will be elongated when you have a VSD. It will be related to the anterior border of that ventricular septal defect and not to the posterior border. So that's important to bear in mind if you're going to be patching that ventricular septal defect. It's a long bundle. It courses down and then it branches, of course, to a left bundle branch on the right side and right bundle branch on the left side. However, if the atrial chambers are in the wrong arrangement, that is to say, you have a morphologic left atrium on the right side, receiving the pulmonary veins, and your morphologic right atrium on the left side, receiving the systemic veins, systemic caval veins, then you have the ventricles in the correct position as in a normal heart. The right side of ventricle would be a morphologic right ventricle, left side of ventricle would be a morphologic left ventricle. So in that scenario, you would have the usual arrangement of the atrioventricular conduction bundle as you expect, say in heart with isolated ventricular septal defect, for instance.
Thank you, Professor Ho. And the next question I think I could be answered. Could we use the cardiac MRI instead of the echo to evaluate the post-repaired transposition great artery patient? If echo view is suboptimal, or using Trans-Esophageal echocardiography for following up? I think the main answer is possible to find in the last guideline published from the American Society of Echocardiography, especially for using the multimodality imaging in the patient with the transposition of the great arteries. Actually, the cardiac MRI is it's possible to using, it played the major role as the gold standard for the evaluation of the patient when transposition of the great arteries. We could use it primarily to image the patient after the surgical intervention, also to provide more information regarding this possibility for the performance and the visualization of the viability, and also for the quantification analysis assessment of the valvular function and accurate evaluation of the baffles, conduits, and extracardiac structures which the branch pulmonary arteries, also in the aortic arch. Also the transesophageal echo in adults with the repaired TGA, we can't use it in those of kind of the patient. We could have the poor window from the transthoracic echocardiography. Also during the intraoperative imaging actually in the patient with arrhythmias who needed to have the required cardioversion about this arrhythmia. So the mainly echocardiography and MRI is the main imaging modalities that could give us the answer about the reproducivity of anatomical and hemodynamical information of that type of the group of the patient. The other question is, can we give tips on optimizing echo and assessing the coronaries in patient with the TGA? I think this is actually the one of the possibilities to analyze the anomalies of the arteries in that population. Then we reduce the velocity of the color Dopplers, and then we going to 3 o'clock for analyzing the left coronary artery, and 1 o'clock for the right coronary artery. This is, I think, it was written from the last guidelines from the Professor Merrill Coyne. So, Professor Ho, do you want something to comment about this?
No, I think you covered it very nicely.
Okay. I don't see any other questions, but we could actually go to the further in the next session.